study of the difference of platelet indices in dengue fever and dengue hemorrhagic fever. As you all know, dengue is an acute viral fever with epidemics coming, and thrombocytopenia is a common laboratory finding. But there is inadequate data on platelet indices in dengue infection. We have studied PCV, other parameters, but not the dengue indices. So, a prospective observational study was conducted between May 2019 to May 2020. The platelet indices we used were mean platelet volume, platelet distribution width, platelet crit. On day 4 of the fever, we use them as a platelet activation indicators. So these indices were compared between the groups of patients who had dengue fever and dengue hemorrhagic fever. There were about 101 patients. Out of them, 67 were dengue fever and 34 were dengue hemorrhagic patients. And the median platelet count was 70 in dengue fever and 43,000 on day 4 of dengue hemorrhagic fever. And obviously, it is significantly low in the dengue hemorrhagic fever. We all knew that. And our finding was like patients who developed dengue hemorrhagic fever, we found the median platelet crit, mean platelet volume was significantly lower than dengue fever patients. Namely, dengue fever patients platelet crit was 0.78% and 0.47% in dengue hemorrhagic fever. And mean platelet volume, it's 9.9 in dengue fever and 9.4 in dengue hemorrhagic fever. So there is a significantly lower platelet crit and mean platelet volume when compared to dengue fever with dengue hemorrhagic fever. But there was no significant difference in platelet distribution width. And we use this comparison using the Wilcoxon-Mann-Whitney test because our distribution is not equal, it's non-parametric, and we use the median. In conclusion, there was significant decrease in mean platelet volume and platelet crit with decrease in platelet count coupled with hemorrhagic tendency. In addition to the platelet count, we suggest platelet indices such as mean platelet volume and platelet crit can also be useful in monitoring the progression of dengue fever and dengue hemorrhagic fever. So we need to have large studies to get the standardized values, such as now we are using PCV. So then we can compare with the PCV which we are using at the moment and decide which is the meticulous indicator of monitoring dengue fever and dengue hemorrhagic fever. Thank you.
Ms. Champika have questions?
Yes. Is the justification of selecting day 4 is to use as a predictor? Day 4. Why did you use day 4 as a platelet count? Yeah.
She wants to know why you use day 4 to start to do the assessments. Was it a predictor or something?
Okay. Day 4 because we know the patient's going to critical phase in day 5. That is the reason we use day 4 full blood count to get an idea whether they will go into critical phase or not, madam.
I have another question.
Yeah.
Now, PCT is a manifestation of a low platelet count. So when you have a low platelet count, anyway, the PCT will be low. So that is again another finding associated with the low platelet count, isn't it? So you cannot say that is really predicting something, but mean platelet volume, is your findings different from elsewhere findings? Because mean platelet volume is in yours is reduced. In some studies, it is increased.
Madam, it is difference is like when it is increased, it's a what they say is there's a destruction of platelets. When mean platelet volume is increased, then there will be new platelets. But when mean platelet volume is reduced, what will happen is we can identify as a bone marrow suppression is still going. So we know there will be hemorrhagic tendency. There will not be any new platelets. So that is also found in other studies as well.
Okay.
Just have one question for you. Does the PCT add any value to other than platelet count? Does it give any additional information in terms of clinical care?
Not really, but platelet crit, when platelet crit is low, we know this patient is having low platelet count, and actually not as a single value. With comparing the other indices, the other studies they have found PDW also has significance. If we compare with them also, then we can get an idea because
Taking it as a whole.
yes, overall, not the single value.
Thank you.
Thank you, sir.
I didn't know that you were in KDU.
Okay, we can give a few minutes for the judges to evaluate and and if you give me the go ahead, madam, we can go to the next presentation.
I can go ahead.
Okay.
I don't ask the others.
He's
No,
all
we
right,
have a
madam.
go
He's
ahead,
here.
yes.
Next will be presentation 5.
Right. Yeah.
Poster presentation 5, inflammatory profile of HIV uninfected and co-infected patients with tuberculosis, a prospective cohort study and immunological network analysis. The authors are Dr. Du Brun E, Dr. Fukutani KF, Dr. Schutz C, Dr. Maintages G, Dr. Ariaga MD, Dr. Cubilus Angulo, Dr. Sher A, Dr. Ryu C, Dr. Wilkinson KA, Dr. Andrade BB, Dr. Wilkinson RJ, and the presenting author will be Dr. Rockwood N.
Good afternoon, everyone, and thank you for the opportunity to present. So the influence of HIV co-infection on the immune system and the immune response to mycobacterial tuberculosis remains poorly understood, as each pathogen compounds the immunopathology associated with the other, adding to complexity. And then further to add to the mix, the intertwined effects of antiretroviral therapy and its effect on immune reconstitution and immune clearance of Mycobacterium tuberculosis during anti-tuberculous therapy need to be considered. So we applied a systems immunology approach. In a cohort of 130 patients who were based in Hylitra Township in South Africa, we measured 39 markers of inflammation, including immunoactivation, tissue remodeling, oxidative damage, and we measured using PEGS technology plasma of TB patients who are undergoing treatment. And we measured this at 3 different time points, at the baseline prior to TB treatment, 8 weeks, and at 5 months of treatment. We also measured markers of immunosuppression such as CD4 count and HIV viremia. And just to give a few cohort characteristics, these were all cultured and completely. Out of these patients, 58% had cultured and converted at 2 months of TB treatment. 8% had unsuccessful treatment outcome, including death and failure during treatment. 58% of these were HIV co-infected, and out of the ones who were HIV co-infected, 27% had suppressed HIV viral loads at baseline. So I'm going to talk through some of the results now. So first of all, I just draw your attention to this Venn diagram. What is it showing? It's showing essentially the response to TB treatment compared with baseline both at 8 weeks, as shown in this green circle, and at 20 weeks, as shown with the yellow circle. And obviously the intersection is where the results were the same. So red means that the correlate increased, blue means that it decreased. So first of all, you'll see both at 8 weeks and at 20 weeks, the majority of correlates, all these ones, which I won't name individually for lack of time, had decreased. But there were some that actually they increased at 8 weeks, such as IL-1 alpha, but then by 20 weeks, it had decreased. Similarly, IL-10, which we know is anti-inflammatory, it had decreased at 8 weeks, but it had increased at the end of treatment. So then I take you to this heat map. This heat map is essentially showing you at a glance in these 39 analytes how the response to treatment at baseline, 8 weeks and 20 weeks.
Okay, now it's the time for the questions from the judges. Madam, if you wear your headphones, you can hear the virtual results. Okay, madam.
We couldn't finish the presentation, isn't it?
No,
Yes.
no, unfortunately not.
Do we have any questions, madam?
No.
Okay, sir.
What's the take-home message?
The take-home message is that essentially when we constructed these network analyses, which are shown here, that the density was greatest at baseline and at 8 weeks, and had substantially decreased by 20 weeks. And this density was actually not driven by response to TB treatment. It was actually driven by suppression of HIV viremia. So this has obvious translational implications that when you're treating HIV co-infection, you must start antiretroviral therapy early. And then the second thing was that we found this particular marker, IL-1, IL-17, was the most predominant network node. And this is absolutely novel. It's something that's well known in allergy. Professor Asita will know this. But essentially, we found that it is strongly linked with HIV viremia. You give antiretroviral therapy and you suppress these patients, that decreases. So again, this has interesting implications for correlates of disease severity and potential biomarkers.
Thank you, madam. Now, if I get the go-ahead from the judges, we can go to the next presentation.
You can go ahead.
Number two. Time maybe. Utilization of time.
Advanced. Shall we go ahead, madam, to the next presentation?
Please.
So shall we? Okay. Presentation 2. The first genotypically confirmed case of artemisinin-resistant malaria in Sri Lanka. The authors are Dr. Fernando SD, Dr. Gunasekara WMKTDAW, Dr. Hapuarachi HC, Dr. Ku C, Dr. Vitarana HN, Dr. Munaz MM. The presenting author today is Dr. Veerasekara CJ.
Good afternoon, and thank you very much for giving me this opportunity to present on the first genotypically confirmed case of artemisinin-resistant malaria in Sri Lanka. Sri Lanka was declared as malaria-free by the World Health Organization in 2016. Artemisinin-based combination therapy is the first-line treatment recommended by the World Health Organization for Plasmodium falciparum malaria. And ACT resistance is defined as the presence of parasites beyond 3 days of treatment, and it is associated with mutations in the propeller domain of the Plasmodium falciparum PF-Kelch13 gene. In 2019, a Sri Lankan visiting from the Democratic Republic of Congo had gone on a short trip to Rwanda 1 week prior to his return to Sri Lanka. Upon return to Sri Lanka, after 5 days, he developed fever and was diagnosed as having Plasmodium falciparum infection another 5 days later. He was treated with artemether-lumefantrine per the national guidelines, and he cleared the parasites within 3 days. However, he developed fever again approximately 2 weeks later and was found to have Plasmodium falciparum parasites in the blood smear and was classified as a recrudescence. This time he was treated with dihydroartemisinin piperacin, the second-line anti-malarial, to which he responded and remained negative throughout the follow-up. So the objective of this study was to confirm the presence of mutations in the Kelch13 gene that confer artemisinin resistance in this patient. Filter paper blood samples were taken per routine prior to the initiation of anti-malarial therapy in both instances. And these samples were sent to the Environmental Health Institute in Singapore. The parasite DNA was extracted, and then amplification was done through a conventional type of a nested polymerase chain reaction, and the purified products were sequenced and analyzed and looked for the presence of this gene, Kelch13 gene, and its mutations. When considering the results, low parasite count, when considering the results, the near complete K13 gene was sequenced in the sample taken during the primary infection, and 2 amino acid substitutions, namely the R561H and the K189T, was found within this gene. The first one, the R561H, is found within the propeller region of the K13, and it is known to be associated with artemisinin resistance in Southeast Asia. Interestingly, a recent emergence and a clonal expansion was seen recently in Rwanda. The K189 mutation is found within the propeller region. Non-propeller region is not known to confer artemisinin resistance. So in conclusion, this is the first report of Plasmodium falciparum K13 gene genotypic detection. And in considering the current epidemiology, we may have got this infection in Rwanda. And as Sri Lanka continues to report imported malaria cases, early diagnosis, treatment, molecular surveillance, and efficacy testing is currently being carried out by the ANC to prevent it. Thank you.
Okay, now we have time for the questions. Madam?
Where was it performed, the gene amplification? In which laboratory?
The gene amplification was performed in the laboratory in the Environmental Health Agency in Singapore, madam.
Right. Okay.
Sir?
Okay. Does this have implications for us? Does this have implications for Sri Lanka, because we have eradicated malaria?
We have eliminated.
Yes, so we eliminated malaria and we now use artemisinin as first line. Does this have any implications for us? Should we be doing it for every malaria case?
Actually speaking, we should be doing it for malaria cases that do not respond want to treat.
So it should be part of the
It should be
diagnosis or treatment
yes,
resistance.
it should be because up to now there are no evidence of absolute treatment resistance. But
And we don't have capacity to do this yet.
uh, at the moment, we don't have to do that.
Thank you.
Thank you, sir.
Thank you, madam. Madam, did you hear the questions asked by Asita sir?
I did.
Okay, yeah, she hears. Yes, no, she heard. Shall we go ahead, madam?
Definitely.
Okay. Sayana? Yes. Three. Poster presentation 3. Knowledge, attitudes, and practices on COVID-19 among medical students and pre-interns in Sri Lanka. The authors are Dr. Padmasiri MSN, Dr. Dharani UGAN, Dr. Matthias AT. The presenting author today is Dr. Padmasiri.
Good evening, ladies and gentlemen. I'm Satisha Patmasiri, one of the co-authors of this study and also currently an intern medical officer. So, COVID-19, like recent coronavirus pandemic is associated with increased morbidity and mortality, as well as good knowledge, correct attitudes, as well as good correct practices would help us in combating this pandemic in a successful way. So our study was aimed at assessing knowledge, attitudes, and practices about COVID-19 among medical students in Sri Lanka. This was a cross-sectional, descriptive cross-sectional study which was carried out among medical students of Faculty of Medical Sciences of University of Sri Jayapatanipura. We recruited all students from first year up to the final year, and which included pre-intern medical officers also. So this our study instrument that we used was a online questionnaire that was posted by online platforms, and we had a response rate of 80.4. So if I move on to the results or the main outcome of our study, 73.9% of our population had a good overall knowledge about COVID-19, as well as the mean knowledge score was around 7.11 with a standard deviation of 1.19, and maximum score was 10. We observed a relatively low knowledge when it comes to areas such as specimen storage and specimen transportation. The knowledge score were higher as the academic year advanced. Like the first year, the mean knowledge score was 6.49, while in the pre-intern sector, it was around 7.41. And that difference was statistically significant. If I move on to the attitudes, 92.73% of our population were worried of their family members getting contracted with the illness, and also 58.1% were worried of the social stigmatization of themselves as well as their family members, which was imposed by the society. And also 97.8% of our population were among medical students were ready to accept isolation in a healthcare facility in case they get contracted with COVID-19. So what we consider as the most important outcome is that the sequence of wearing PPE, that knowledge was possessed only by 51.91% of our population, and also the correct sequence or the correct practice, although the mask hygiene, the knowledge about the mask hygiene was good, the correct practices to remove the mask was low as 53.05%. So in conclusion, medical students showed expected level of knowledge about the more training should be given to medical students as well as healthcare professionals in handling PPE, like the sequence of wearing PPE should be.
Now it's time for questions, madam.
Yes. Did you check on the sources of knowledge as well, or did the faculty conduct any sessions for these, any other sources of knowledge? Did you check on your study?
Madam, we made a questionnaire like based on the guidelines that were existing, like the guidelines that had been published by Health Ministry regarding specimen transportation and specimen storage. The questionnaire was based on those information.
Right.
I have no questions. I have no questions. It's
Go
very
ahead.
clear
Go
what
ahead.
she's saying.
Please go ahead.
Thank you.
Thank you, madam.
Yeah, okay, thank you. You may smile.
Okay, good. Thank you.
Shall we go ahead, madam?
Yes, please.
Okay. Poster presentation 4. A descriptive study on preparedness on COVID-19 among pre-intern MBBS graduates in 2 Sri Lankan state medical schools. The authors are Dr. Fernando ADA, Dr. Nirmal G PC, Dr. Kodituwaku LWH, Dr. Sirigampola M, Dr. Atapattu PM, Dr. Vijayakon PWM CSB, Dr. Vijayakon CS, Dr. Vasalatantri S. The presenting author today will be Dr. Kodituwaku LWH.
Good afternoon, ladies and gentlemen. I am here today on behalf of my research team to briefly talk about the descriptive study we carried out on the preparedness for COVID-19 among pre-intern MBBS graduates in 2 Sri Lankan medical schools. The main reason for the choice of topic was to evaluate how prepared the new set of interns who are about to enter the health service in the time of this problem, which the whole world is struggling with, and we presume that their knowledge would accurately reflect on the potential way they would handle the situations which would arise in the health setting. So we assess the knowledge of the pre-interns on different aspects of COVID-19 along with the performance they had at the final MBBS examination, along with the sources of knowledge they used with which to familiarize themselves with COVID-19. The data collection was through a web-based questionnaire administered to all pre-intern MBBS graduates of of the universities of Colombo and Sri Jayawardhanapura. And out of the 346 pre-interns who were reached, 271 responded with a 78% response rate. And then considering about the results, it seemed that 92% of the respondents had used news media and social media as their main source of information on COVID-19, whereas only 66% had used scientific sources like government medical issues and scientific literature as their source. And we assessed their knowledge on various aspects on COVID-19, and a total of 35 marks were allocated for the knowledge. The mean knowledge score was 18.69, whereas 148 pre-interns, that is 54.661, scored more than 50% out of the total. This graph shows you the various aspects we posed questions on, and the best scored area was on disease transmission, while only 23% of the pre-interns obtained more than 50% for questions on the correct usage of personal protective measures. And we also compared the knowledge score with the performance at the final MBBS examination and the sources of information they used. And there was a significant correlation with the higher performance at the MBBS examination and usage of scientific literature, with achieving more than 50% out of the total score. So the conclusions we derived that there was a positive correlation with the sound knowledge on COVID-19 with a better performance at the final MBBS examination and also with the usage of scientific literature and also the knowledge on areas like disease transmission, lab diagnosis and natural history of the disease was significantly better than areas the knowledge on areas like correct usage of PPE. So we recommend that all the pre-interns who are to enter the health services during this time of pandemic be provided with targeted and holistic care while integrating the COVID-19 into the medical curriculum. Yeah. Thank you.
Okay, next up is the questions from the judges, madam.
Extremely different scores between the domains that you have studied, like subsections, isn't it? Like the PPE.
Yes, yeah.
Is it, what is the postulated possibility? What is the possibility like?
Like a significant, staggering majority of the population had used social media and news media as their source of information. So those sources of information are highly likely to provide information on technical aspects like PPE usage. So I think that may be contributing to the difference of knowledge.
Right.
Yeah, so you suggesting that before they take up any medical job, they will training on PPE and other COVID related.
Yes.
Okay, thank you, madam.
Most of the communication from social media. It's sad.
Madam, shall we go ahead?
Sure.
PP6.
Are you ready?
Okay.
Come again. Is there something that I don't see here? Yeah, it's like collecting.
Poster presentation 6, associated comorbidities, target achievement of young hypertensive patients with essential hypertension attending the VP OPD clinic, Provincial General Hospital, Badulla. The authors are Dr. A.M.S. Mihirani, Dr. S.C. Vidyaratna, Dr. P.K.B. Mahesh. The presenting author today is Dr. Chatturi Lianapathirana.
Thank you. So our research was about associated comorbidities, target achievement of young hypertensive patients attending the clinic Badulla. Essential hypertension, there have been a lot of studies done in Sri Lanka and also in other countries about young hypertensives. But I mean, in Sri Lanka, the prevalence is around 17.4%, but none of these studies have found out what is happening to these patients once we start on treatment. So our aim was to see once we start treatment, what happens to these patients, and as well as before we start, what are the comorbidities and risk status associated with these patients. Now, we didn't look at the whole risk assessment. We didn't do. We checked the most common stuff that we check usually in the clinic. That is, we check the WHO total risk score. For that, we check few risk factors. Those are the ones that we have checked, and then we compare this risk status at the point of start of treatment and after the follow-up period. So we recruited 85 young hypertensive patients between 20 to 40 years with a follow-up of at least 6 months. The 6 months cutoff was taken after several, again, research studies showed that at least 3.5 months we need to have for the patients to have to assess their target achievement. So there was a data extraction sheet that we filled and a descriptive analysis was done. So coming on to results, the median age of our group was 35 and they ranged between 33.5 to 38 years. With a male to female ratio was 1.1 to 3. So there was a female predominance, which was not really in keeping with the studies that was done in Sri Lanka and as well as in other countries. I will come to that why we thought that would have been in our study. And the median follow-up period was in fact more than like 3.5 years. So ranging from more than 1 year to even 6 years. So there was a good follow-up period for these patients. And most of these young hypertensives were referred after finding it incidentally. So when assessing the associated comorbidities, trying to enlarge this. You can see. So, yeah. So this at the initiation of treatment, most of them belong to stage 2, and only 27% belong to stage 3. But most of them were they went into have normal blood pressures and stage 1. So more than.
Stop you here because the time you were given by the disease. Just give us your conclusion.
So, so young hypertensives with essential hypertension had relatively overall cardiovascular risk in the group we have studied, and also they showed good response to antihypertensives. But I have to mention our limitations. We cannot generalize this to the general population because we recruited people who are coming self-referred to the OPD after finding incidentally high blood pressure.
Okay. Now it's time for questions, madam.
I have a question. Though blood pressure targets were achieved, what about the other risk factors that you have listed in this study, like diabetes, LDL, obesity, smoking, and things? Did you assess those also at the end of the study? Because you cannot conclude otherwise that they are low risk group.
Yes, we checked the WHO risk status, and I have put the numbers every recruited patient and the target achievement I have mentioned in this bar diagram, where we consider all these when we check the WHO risk score after the follow-up period.
Okay.
Yeah, fine. I'm clear.
Okay. Thank you, madam.
Thank you.
You are in Basel, right?
Yes.
I hope you continue doing this kind of work.
Yes. Nice guidance. We have all the years.
Can we go ahead, madam?
Yes, please.
Poster presentation 7. Initial experience with video capsule endoscopy in a tertiary care center in Sri Lanka. The authors are Dr. Arya Singha JVS, Dr. Rangana HMP, Dr. Anuttara HRCS. The presenting author today is Dr. Pereira KDR.
I'm going to discuss with regard to my study. It is initial experience with video capsule endoscopy, and which was carried out at Colombo South Teaching Hospital, which is one of the leading tertiary care centers in Sri Lanka. Now it's about the video capsule endoscopy, and which was introduced in year 2000, and which has revolutionized the evaluation of small bowel disease because it is non-invasive and better tolerated by the patients. And we carried out a descriptive study, and where the patients who underwent capsular endoscopy from its initiation 2017 until June 2020. And the data were collected from hospital computer database. And we included the patient demographics and the indications of the study and the quality of bowel preparation and its findings. And all the studies were carried out using MirrorCam system by Intromedic. Now, the study included 54 patients with a mean gastric time of 54 patients, and the 45 cases for about the small bowel bleeding, and 6 and 3 cases for abdominal pain and chronic diarrhea per se. And the mean gastric time was 52 minutes, and the mean small bowel transit time was 272 minutes, and bowel cleanliness was good to excellent in about 54% of the patients. And overall lesions identified, and ulcers and erosion were the most common lesion identified, which were about seen in 17 patients, followed by angiodysplasia and subepithelial lesions. And active bleeding was evident in 12 patients. And if you look at this figure 2, which I have shown the lesions identified with patients' small bowel bleeding, and small bowel ulcers were the most commonly found lesion, which was found in about 49% of the patients. And interestingly, 31% patients were found gastric lesions. And most patients who were evaluated for abdominal pain and diarrhea, they had normal capsular endoscopy, except for 2 patients who had small ulcers and subepithelial lesions, which was suggestive of lymphonodular hyperplasia. In conclusion, the diagnostic yield of capsular endoscopy, in overall, it was about 58% in suspected small bowel bleeding, but it was comparatively high with a history of patient over bleeding compared to occult bleeding. And but the utility of capsular endoscopy for evaluation of unexplained abdominal pain or diarrhea should be done after careful evaluation, because the diagnostic yield is going to be quite low. And in conclusion, it can be considered a safe but very useful investigation in evaluation of small bowel disease, particularly suspected small bowel bleeding. That is about my study, and I would like to put any questions. Yes.
Madam, do you have any questions?
I'm okay.
Madam?
I'm fine. I no questions.
Sir? She has no questions.
Capsular endoscopy. What's standard of care? What do you consider the gold standard capsular endoscopy?
So it is.
Or is there another way to do it, and what's the difference?
We have several ways to assess small bowel, including MRI angiography, and we have endoscopy, because capsular endoscopy is very interesting, it's non-invasive. And actually, you can visualize the whole small bowel mucosa, because endoscopy you need anesthesia and it's going to be very invasive.
Would you need to confirm something after doing this? The confirmation is like before we do the antigen test, but we know that we do PCR.
Yes, sir. If you found a lesion, and if you want to take biopsies, we can proceed in endoscopy. It's going to be a diagnostic test, and if you want to have therapeutic indication, you can go for endoscopy.
Thank you, sir.
Thank you, sir.
So it's sensitive.
Yes, sir.
Sir, shall we? Yes, 8. Madam, shall we go ahead?
Sure.
Poster presentation 8, out of ICU intubations, study of clinical practice and adverse events. The authors are Dr. W.D.D. Priyankara, Dr. E.M. Manoj, Dr. Varuni Samaranayaka. The presenting author today is Dr. Amanda Ranavira.
I'm going to present the study of clinical practice and adverse events following out of ICU intubations. As you all know, intubation is a life-saving procedure in critically ill patients.
And we come across a lot of patients coming to the medical intensive care unit with adverse events following intubation, like hypotension, cardiac arrhythmias, cardiac arrest, and hypoxia. So that is why we wanted to conduct this study to assess whether these out of ICU intubation practices are acceptable. So tracheal intubations usually occur in safer environments like ICU and theaters, but it can occur in unsafe environments as well, especially in cases of emergency airway management. So our study population was adults more than 18 years who had tracheal intubation in medical wards of National Hospital of Sri Lanka over the 6 months period, and there had been 47 intubations during that period. The commonest reason for intubation was respiratory failure followed by cardiac arrest and low GCS. Most of the intubations occur out of hours, that is after 4 p.m. So 61.7% occurred like that. And considering pre-intubation preparation, pre-oxygenation was done in only 76.6%. Pre-oxygenation is essential in improving oxygen stores during apneic period to minimize desaturation. And considering available monitoring, more than 90% had ECGs, pulse oximetry, and blood pressure monitoring. But unfortunately, CAPNO was not available in any of the cases. So this is essential in confirming the correct position of ET tube in the trachea. And Royal College of Anesthesiologists NAP4 study also suggests that absence of CAPNO is associated with more than 70% airway mortality. Considering the available equipments, none had two laryngoscopes or blade, and alternative airway like laryngeal mask airway was available in only 19.1%. Considering the intubators, only 14 out of 47 had airway training, more than 6 months of anesthesia, and most of them were medicine trainees from, and they were registrars. And when the first intubator failed, then the second intubator intubated. There had been 6 instances like that, and none of them had training in the airway. And out of the 6 second intubators, there were 2 intern medical officers. The commonest hypnotic agent used for intubation was midazolam, and the commonest paralytic agent was dexamethasone, and less than 20% of the patients received analgesic agent at induction. So the commonest adverse event following intubation was hypotension followed by hypoxia and esophageal intubation, and there were other adverse events as well, and there had been deaths as well. So in conclusion, intubation in medical wards are done by less experienced doctors with lack of facilities and has high incidence of adverse events. So we recommend to establish outreach team with airway skills to minimize these effects. We have already done that, and what the current practice is, we inform the medical team to inform us whenever there is a deteriorating patient, and we go by ourselves and assess and intubate. If there has been instances that the equipment are not adequate or the airway is difficult, so we get them down to the ICU and intubate.
Okay. Now it's time for questions. Madam.
I have a question.
Yes, madam.
The adverse effect that you described, can that
Yes.
be due to the original illness that they have than for the intubation per se?
Yeah.
I mean, it could be how
Yeah,
you could
that
conclude
is true,
it as
madam.
an intubation because it could be due to the original illness.
Yes, true, but I think anyway we are planning to re-audit and see, madam. So in that re-audit, we are planning to assess whether the patient had been having hypertension or hypoxia prior to the intubation as well, so that we can get the more appropriate treatment.
Right.
Yes, sir.
It's fine.
Okay. Thank you, madam.
Thank you.
Shall we go ahead, madam?
Go ahead.
Poster presentation 9. perceived competence in end-of-life care among healthcare providers in the intensive care unit, an evaluation in Sri Lankan tertiary care setup. The authors are Dr. Kulasiri, RADS. The presenting author today is Dr. Subhasinghe, SDLP.
So this article is on critical care medicine, and we all know that the need for improved end-of-life care, which is being practiced in both medical or any other specialty ward in medicine, especially in the ICU setup, is very important, especially in a challenged healthcare system like ours. So it's one of the greatest challenges met by us, especially as intensive care clinicians. So this study was conducted in National Hospital of Sri Lanka, involving 240 mixed population ICU staff members working at 7 specialty ICUs over a period of 3 months in 2018. The method we used to collect data was a self-administered scale of end-of-life care in the ICU questionnaire, which was validated and previously used by two studies. It mainly consisted of 28 items, which were considered under 7 end-of-life care domains, initially proposed by Clark and colleagues in I have mentioned in the references. These 7 domains consisted of 7 pathways in which we provide end-of-life care, especially in the ICU. Before considering the 7 domains, we ourselves had 3 subscales to be tested upon the population, which mainly consisted of knowledge, attitudes, and behaviors pertinent to end-of-life care in these ICUs among the staff members. The results gave us these findings. Only 40 participants had passed education in end-of-life care, and majority from the medical staff as well as the nursing staff, nearly 85 to 89%, had achieved best levels of perceived competence in end-of-life care, achieving best scores from the questionnaire. And correlating the level of practice, perceived competence to years of practice in critical care among the medical practitioners, among the doctors, was the only finding which was significant when we considered the subscales like doctors, nurses, and their subspecialties. Only the doctors overall had a better outcome in level of perceived competence when we considered the years of practice. Moving on to the, sorry about the clarity, these 3 graphs show respectively the knowledge, attitudes, and perceived behaviors, the scores they achieved in these 3 domains. All of them were negatively skewed, and all of them showed scores above 4. When we correlated the previous education they had with these 3 domains, only the behavior domain showed a significant p-value less than 0.05. When we considered the 7 domains described by Clark and colleagues, they were also negatively skewed, and 2 of the domains showed significant association with practice and previous education.
Dr. Shani, the time is up, so you need to just conclude this.
Yeah. So from the results,
30 seconds. Conclude.
we concluded we should engage previous among we should engage education among the population early in their training or in their career. So that was the main conclusion.
Okay. Next up is questions. Madam, do you have any questions?
Is it a validated questionnaire that you have administered to the staff? Like, you'd have used several languages because your population is mixed.
Yes, this was validated. I couldn't include the exact reference here. This was the domain reference, but the questionnaire had been practiced in 2 previous studies, and the original authors of the questionnaire, we had taken the written permission from them to include it in our study, and we gave the questionnaire in 3 main languages: English, Sinhala, and Tamil.
Okay. Okay.
Sir?
This is generally a very poor area on our part, isn't it? Anyway, end of life, we don't know how to tell people. Did you look at the nurses?
Yes. Nurses. Yes, I couldn't include all the results here, but this one, I compared the medical staff, the doctors, nurses, also the life and the stuff. We had 4 physiotherapists in our study. In this one, I have shown here both domains. I compared these two because there are only 4 physiotherapists. We have, excluded them from the study because they were a very small sample. So the nurses have shown 90% best level of competence self-personally.
It's because they've been there for a long period.
Nurses, no, there was no association as such. We went with the previous education and the years of practice. Nothing had an association except for the doctors who had an association with the years of practice they had done.
Thank you. Very interesting.
Thank you.
Thank you.
Yes.
Thank you, madam.
Thank you.
Madam, if you give me the go ahead, we can go to the next presentation.
Please go ahead.
The highest. Poster presentation 10, descriptive analysis of CTD ILD patients, Central Chest Clinic, Colombo. The authors are Dr. Krishna Kumar P, Dr. Sadikin A, Dr. Fernando A. The presenting author today is Dr. Jayasinghe P.A.
Good afternoon. This is our study actually. Why we did this study was we recognize the fact that interstitial lung disease is becoming a more and more common cause of mortality and morbidity in connective tissue disorders. So we actually mainly target on the demographic profile analysis and the HRCT pattern analysis. So we actually recruited 84 patients to this study, and the age was mean age was 54 years, and it was ranging from 16 to 72, and majority of them were females. And as you can see in this chart, the types of CTD ILDs were distributed like this. Majority were included in rheumatoid arthritis group, followed by systemic sclerosis, and we found SLE patients also with ILD, even though it's rare, and inflammatory myositis, mixed connective tissue disorder, and IPF patients, which is newly introduced in TT. And also this is the HRCT pattern. Most common pattern was NSIP, that is non-specific interstitial pneumonitis, followed by UIP. And we have observed organized pneumonia and hypersensitive pneumonia patients as well in our group. So we further analyzed rheumatoid arthritis patients with ILD. Female preponderance was there in the sample, and majority had positive rheumatoid factor. And RAILD HRCT pattern shows NSRP and UFP patterns were equally distributed. And then we analyzed the systemic sclerosis patient. More than 90% were female, and NSIP pattern was observed in close to 80% patients had NSIP pattern. So in conclusion, in our study showed NSIP pattern is the most common HRCT pattern in CTD-ILD. And the important I want to highlight, in rheumatoid arthritis ILD, NSIP and UIP, both patterns were equally observed compared to global, which has found UIP is the most prevalent one. And the debilitated preponderance was observed in all CTD-ILD patients. But in global studies, actually, ILD is mainly described in male patients. But it is also observed in female patients in our study. Actually, recently there was a study conducted in Canada, and we also have found some similar data where the rheumatoid arthritis patients ILD have preponderance of to have an NSIP pattern rather than UIP pattern.
Okay, we can go to questions, madam.
Now these are very high.
1 second, madam. Give me one. The presenter has to wear her earphones. Yes, we can go ahead, madam.
Regarding the patients who are patients with rheumatoid arthritis, is it a drug-induced lung disease possibility? Because most of them are on DMARD and especially methotrexate. Did you look at the number of that also?
Yes, madam. Actually, we have seen that also, but those patients were mainly included in hypersensitive pneumonitis group. But in UIP pattern, we saw only a few number of methotrexate induced ILD. Mostly other categories due to the disease itself.
Okay.
Sir?
Fine.
Okay, thank you, madam.
Thank you. Is this information any different in the South Asian countries like in India?
Yes, different means in South Asian countries, they have CD, the data related to CTD-IAT is minimal. So in our country, actually, recently only 1 or 2 studies are available. So there are majority of studies shows yes, the UIP is the predominant pattern in IAT. But there are some studies where they have found NSIP pattern as the predominant pattern.
Oh, thank you. Thank you. Thank you very, very much.
We're ready to go when you go give the go ahead, madam.
I'm fine.
Please do.
Yes, okay. The final presentation of the session, poster presentation 11, lung function of fuel handlers exposed to volatile organic compounds. The authors are Dr. Varnakulasuriya T, Dr. Madhagoda K, Dr. Katahachi D, Dr. Liu D, Dr. Aryavanshu J, Dr. Ratnayaka P, Dr. Disanayaka T, Dr. Disilva D, Dr. Devanarayana N, Dr. Sheepers P. The presenting author today is Dr. Vadasingha P.
This is a part of a study which we carried out to look at the effects of volatile organic compounds on various organ systems in the body. In this study, we looked at the lung function values, the lung functions values, and also we try to correlate the association between the selected volatile organic compounds with the lung function parameters of the among the fuel handlers. It was a case cross-sectional cohort study, and in our why our study is unique is because in this study we don't have any data in Sri Lanka as such, and also the data which is published in the regional papers do not have any correlation with the level of exposure with the lung functions. So that was our key points in our presentation. And in our research here, we show that in figure 2, we see that there is a negative correlation with various volatile organic compounds with different spirometric parameters. For example, toluene causes a reduction in FEC, and xylene also causes a reduction in FEC, while benzene and ethylbenzene causes a reduction in the FEF 25 to 75. So also there was correlation with the exposure, the duration of exposure with the drop in lung functions as well in these patients. In both groups were relatively comparable, and then looking at the specific mean spirometric measurements, we did not see any statistical significance despite the spirometric parameters being slightly lower in the fuel handlers groups. And also, when we looked at the spirometric patterns of these patients, we saw that in the fuel handlers, obstructive, restrictive, as well as mixed patterns were more prevalent than in the control group, but this was also not statistically significant. Interestingly, we saw that among the control groups, the level of volatile organic compounds was significantly low, but still we saw a negative correlation with the spirometric parameters in toluene for all spirometric parameters what we measured. So this tells us that there should be some non-occupational exposure to these volatile organic compounds, which cause a decrease in lung functions in the control groups as well. So the main limitations what we saw in our present research was that this sample size was really small, and also we did not match the smoking status from the cases and controls. So in conclusion, we see a decline in lung function, which was more prominent with the days of exposure. And also we saw the different volatile organic compounds affecting different volume, the spirometric parameters. And also there was a non-occupational exposure, which could have suggested the non-significance, caused as non-significance in the spirometric values what we measured.
Okay. We can go ahead with the questions, madam.
Oh. How was the benzene and toluene exposure assayed?
So it was done by a specific, the whole team of physiologists who came from the Netherlands. So they used standardized methods and collected the exhaled air into hopper containers and then took them back to Netherlands and analyzed them in their laboratories according to the standardized methods.
Right.
Sir?
Can you go to that slide? Yeah. Okay. Why do you distinguish ethnicity? What reason is that? What are you trying to get at?
So the ethnicity affects lung function, but then we don't have proper studies in Sri Lanka for the Tamils and the Sinhalese. So why we use this was to show that both groups has more or less similar different ethnicity.
So what do you recommend that we do in these people?
In this study, so what we saw was the decrease in lung function with the duration of exposure. So reducing the duration, we saw about 52 hours per week. So we need to cut down on the duration of exposure and also use personal protective equipment for themselves. Yes, that was what our recommendations were.
Okay, thank you, madam.
Out of curiosity, do you think policemen on streets who also have symptoms, they have mostly lead?
So the thing what you see the volatile organic compounds, in detergents, and then rubber industry. So mostly in the rubber industry and things, but in the policemen, I think they would have mostly carbon particles in their that also can see.
Okay, with that, I would like to conclude the poster presentation session 1 of the annual conference 2020 of Ceylon College of Physicians. I would like to take this opportunity to thank the judges, Professor Champika Bodhinayaka and Professor Asita De Silva. Thank you, sir. Thank you, madam.
Champika, thank you.
Thank you. Thank you very much.